Good afternoon to all participants. Thank you all for attending this international guest lecture held on Tuesday, October 11, 2022. My name is Rico Gandhi, and it is an honor for me to be the master of ceremony for today's lecture. I would like to welcome all participants, especially our honorable supervisor, all anesthesiologists from around Indonesia and abroad, my senior and fellow residents of study program of Anesthesiologi and Intensive Care, University of Sumatera Utara, and all the other audience that can be named one by one. This event is held by the study program of Anesthesiologi and Intensive Care Unit, University of Sumatera Utara, and today we are honored to be joined by the head of the study program of Anesthesiologi and Intensive Care himself, Dr. Andriamuri Prima Putra Lubis, Anesthesiology Specialist, Intensive Care Consultant. Good afternoon, Doctor.
Good afternoon.
Thank you for joining us today. I hope you are well wherever you are. In today's event, we are going to be lectured by the international expert, Professor Dr. Dilip Shende from Department of Anesthesia, Pain Medicine and Critical Care of All India Institute of Medical Science, AIIMS, New Delhi, India. Good afternoon, Professor. Can you hear me? Good afternoon, Professor.
Masih di unmute.
Can you hear me?
Yes, I can hear you.
My voice is clear.
Yes, your voice is clear.
Thank you so much.
Thank you. I hope you are well, Professor. Thank you for sparing some time of your schedule to share your knowledge and experience with us today. The topic of today's international lecture is, in limited setting, how to provide optimal critical care, especially in support therapy and hemodynamic monitoring. Before we start our agenda today, we will listen to the national anthem of Indonesia, Indonesia Raya. Okay, ladies and gentlemen, to start our agenda today, together we will listen to the greeting speech from the head of study program of Anesthesiology and Intensive Care, Dr. Andriamuri Prima Putra Lubis, Anesthesiology Specialist, Intensive Care Consultant. To Dr. Andriamuri, the time is yours.
Okay, thank you, Dr. Rico Gandhi. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to our dear speaker, Professor Dr. Dilip Shende from All Indian Institute of Medical Science, New Delhi, India, and all participants in this webinar. It's such an honor for our study program of Anesthesiology and Intensive Care Medical Faculty of University of Sumatera Utara to have such a remarkable speaker. As we know, the practice of anesthesiology has become increasingly complex. Not only the clinical side of care are expanding, but the challenge of the clinical management have also increased. Caring for critical ill patient is challenging, especially in a resource-limited setting, where the burden of disease and mortality from potentially treatable illness is higher than in resource-rich areas. Barriers to deliver high-quality critical care in this setting include lack of epidemiologic data and context-specific evidence for medical decision-making, deficiency in health system organization and resources, and institutional obstacle to implementation of life-saving intervention. That is why a better understanding of critical care outcome is essential for improving critical care delivery in a resource-limited setting. And today, we are having an international guest lecture with the topic in a resource-limited setting, how to provide optimal critical care, especially in support therapy and hemodynamic monitoring. As the main idea of this presentation is that we could contribute to give a better quality of critical care. Last but not least, I would like to thank to my teacher, Professor Dr. Dilip Shende, for your willingness to deliver the knowledge to us. And we are waiting for another opportunity to have you as our source person in the second North Sumatera Conference on Emergency Anesthesia Critical Care, which will be held at Medan on March 2023. Thank you, Prof. Thank you, Dr. Rico.
Thank you, Doctor. Now it's time for us to start the lecture. I will hand over the meeting to my fellow resident, Dr. Akmal Fahrezzy, as moderator. To Dr. Akmal Fahrezzy, the time is yours.
Thank you, Dr. Rico. Good afternoon, ladies and gentlemen. Welcome to study program of Anestesiologi and Intensive Care Medical Faculty of USU International Guest Lecture. I am Akmal Fahrezzy, and I'm going to be your moderator today. We have the speaker of this lecture today who are already with us, the Honorable Professor Dr. Dilip Shende. Hello, Professor. Thank you for your time here, Professor.
Can you hear me now?
Yes, Professor. Thank you, Professor.
Okay, so should I start my talk?
I'll explain. I'll read your curriculum vitae first, Professor.
Okay, sure.
Please. Yeah, thank you, Professor.
Thank
you. Yes. Ladies and gentlemen, the topic for today's lecture is about, in a resource-limited setting, how to provide optimal critical care, especially in support therapy and hemodynamic monitoring. The topic will be presented by Professor Dilip Shende for around 30 minutes, and after that, we'll have a discussion session. And first of all, let me introduce our honorable speaker. I will read his curriculum vitae. Professor Dr. Dilip Shende is designated professor of All India Institute of Medical Science and registered with Specialist Registration Medical Council of India. Professor Dilip Shende has been through a medical doctor at Chandigarh, Specialist Training Authority at UK, awarded the certificate of completion of specialist training. Current employment as Professor Department of Anesthesiology and Intensive Care at All India Institute of Medical Science, New Delhi. Professor Dilip Shende have been worked as consultant anesthetist with NHS UK from January 2011 up to December 2012. Also have been worked as Commonwealth Medical Fellow for a period of 1 year. Experience in pediatric anesthesia since 1991 in Birmingham's Women's Hospital, UK. Mainly do ophthalmic pediatric anesthesia with total patient children around 10,000 each year, preterm infant 200 each year, and infant 1,000 each year. Professor Dr. Dilip Shende have been published 50 research publications in various renowned international journals, such as International Anesthesia, Anestesiologi, Anesthesia, and Intensive Care, and so on, which 5 publications are cited in Smith textbook of pediatric anesthesia. Professor Dilip Shende have been post a paper and poster presentation in various national and international conferences, which include American Society of Anesthesists. Now, without further ado, please welcome Professor Dilip Shende to make your presentation. Professor Dilip, the time is yours. Thank you, Prof.
Let us start again. The basic critical care service, whenever it is going to be provided, there are certain components of it. So one is transport and triage. The patient comes to ED for management, where there is a hemodynamic management, he may require organ support, and then once he improves, he step down to the critical care. So these are the various components of the critical care which we will be discussing. How we manage in the patients, how the patients are managed in the rich people, rich country, and countries where there is a limitation. So the critical care in low-income countries remains in infancy and in the most of the hospitals. Okay, this RAID and this is low-income countries and other high-income countries. So why it remains in infancy? Because most of the patients treated in this part of the world are either of pneumonia or febrile illnesses, road traffic accidents. Obstetrics not very well developed, therapeutic care not very well developed, many obstetric complications, some surgical emergency. That is the group of finding you get in this country. So there is huge difference between the spending in the developed world and underdeveloped country. So if you look at in the US is one of the richest country in the world. It spends around $10,000 per per capita. Per capita spending is $10,000, while in UK 4,000 or $5,000, where in India it is around some 500 rupees, which can come to $10 to $20. So this is something. So why we are bothered about the critical care? Because in developed world, they are managed well and there are not very high number of preventable deaths. But in the country like poor countries, low income countries, these deaths are absolutely preventable by doing certain precautions. So if you look at it, the preventable deaths is much higher in low income, low middle income countries rather than high income countries. You can see it going down like this. Deaths potential preventable with critical care, so there is a lot of scope of improvement. So what should you do is efficient use of your resources. This is published in one of the studies. So for that, how do you efficiently your resources? Short-term training, protocolizing the treatments, optimizing basic health care. So you can say health stopping, ABC approach. So in short, it is very easy to say than done, but these are certain mechanisms by which you can improve. Now, pre-hospital care. An efficient pre-hospital care system will save substantial amount of preventable human loss. Now, pre-hospital care is excellent in high-income countries. You can see it's well-developed emergency systems, modern patient monitoring system, trained paramedical staff, and every second is accounted service is vital. So what we needs accreditation system, needs trained PM staff, adequate funding, good maintenance. So all these things are out of the hands of doctors. So now let us see how transportation takes place in research rich countries. There is availability of everything. There is availability of ambulances, there is availability of aircraft, helicopter, plenty of manpower, they're all trained manpower, plenty of equipment, plenty of, they have got very good training also. And then we go to countries like India or other countries which have got not so many resources. See, there are two classes of people in our country where the urban area you may get everything like ambulance and you may get a chopper also to fire the patient. But you go to the other part of the country, the rural, there is nothing actually. Nothing, and what they are trying to shift their patients are with their homemade, things which on which they are shifting a patient. You can see here it is a cot where they will sleep. On that they are putting this small size kid and taking away to the hospital. Look at the similarly some same kind of transfer mechanism. Here somebody is transporting a baby on his shoulder. So various kind of things are there. So it is very variable. Emergency management system is very important. So what is the role of triage? Triage and emergency treatment have been identified as among the weakest part of the health system. So this has been nicely said. The maximum number of deaths or complications occur in usually emergency area because the triage system is lacking over there. That leads to delay in identification, and that leads to delay in initiation of treatment, and that sometimes leads to delay, leads to the bad outcomes. So triage is very important. Triage helps prioritize. I will tell you the example like if there is a catastrophe or there is a, lot of huge accident, a lot of people are made the trauma and they are coming to the hospital. So first triage you have to do is who needs immediate surgery, who are the patients where nothing can be done, who are the patients who need anesthesia. So you triage them according to into the color coding, black, blue, green, and red. And so the staff identifies the what patient is required and accordingly things. So triage has got very important role. Now another facility is oxygen. There are a lot of news in our country that many times many patients have died because of disruption of oxygen supply. So this kind of things should not happen, but they still happen. Now, just a few words, few slides about the critical care services in India. So there are basically two types. One of the government hospitals, one of them is our hospital, also government hospital, but it is different. So what is the benefit? There are three basic care that charge for certain antibiotic and disposable, which patient ends up spending 1,000 to 5,000 a day. But the hospital is so overloaded with the patient that hospital becomes very patient unfriendly. Then corporate hospitals are there. They have got state-of-art facilities, expensive reach and super reach, and it is beyond the reach of a common man. And sometimes the expense may reach to up to 100,000 INR a day. And many times patient may get exhausted of his resources and get anesthetized in the private hospital. So it is very expensive. Public charity trust hospitals are spoken about. So assessment and monitoring, physiological observation. So this is most important. Whatever resources are limited, this clinical examination and other tools can be always used for evaluation, assessment, and management. So clinical examination, simple bedside tool, simple guidelines. Initial assessment should include heart rate, respiratory rate, systolic blood pressure, level of consciousness, oxygen saturation, and temperature. This is National Early Warning Score. This scoring system is used very commonly abroad also in the world. So these are simple parameters based on like respiratory rate, oxygen saturation, whether patient requiring oxygen supplement, systolic blood pressure, heart rate, level of consciousness, and temperature. So zero is everything is normal, like respiratory rate is 20, saturation more than 90. So it's like that. And then accordingly you score the patient. If this is very important, if score is more than a 4 or 5, you alert surgical team and senior nurse, then assess airway breathing circulation, use chart and note. And if score is more, you can implement oxygen IV access, fluid management. Modified warning score includes an addition of urine output. This early warning score is very good for the assessment of a patient who requires advanced care or not. So a modest proposal is that make the patient center. Okay. Unique personal goals and desires, defining start and stopping the route. Unique expression of a disease, defining special values for the patient. Unique response to treatment. Give your patient a fast hug at least once a day. This is published in Critical Care Medicine 2005 by John Lewis Vincent. John Vincent, had anybody met him? He very often comes to India to deliver lectures, lectures and classes for conferences. And he's a very lively person and he has published this. This fast hug is a mnemonic. Fast hug is a mnemonic which tells you what all things can be done in the medical and surgical. So F starts for a feeding, that is either meal by mouth, PPN, enteral feedback. A is for analgesia, you give a vascor. S is for sedation that can be assessed along with sensorium by Glasgow Coma scale or Ramsay sedation scale. Thromboprophylaxis, temperature, tubes also, so you can include in that. So head up, hemodynamics for age. For U, ulcer prophylaxis, urine output. For G, glycemic control. S, spontaneous breathing trial, supplemental oxygen mask, NIV. Okay, and then there is another this SBID, that S is for SBT, B for boil management, I for intervening catheters like A line, CP, catheter, Foley, balance, E for de-escalation of drugs or delirium. So what is it if you go to a patient, you know faster, what he says, so you may slip on certain parameters. You may forget to ask about what happened. There is so if you have got this in your mind, you can always you may not miss anything. So what are let us see what all you can do in various setups. Resource limitation setup, monitoring, cardiovascular support, respiratory support, and renal support. Right? In severe resource limitation setup, what are you can have ECG, X-ray, NIBP, cardiovascular support you cannot have anything. Respiratory support, oxygen therapy, suction, nebulized. Here you can have vasopressor, drugs and everything. Renal support, diuretics and medical treatment. So monitoring and organ support is very important. You can see in today's era we require very good monitoring system to manage a patient. Like you need a multi-channel monitor, it can give as many as monitoring parameters, apart from ECG, NIV, and all that. You need multiple this thing, chronometer, multiple this thing, to give the infusion sets, infusion form. You can have target control infusion forms also to give sedation to the patient. So a lot of equipments are required. These are basic monitorings as I spoke earlier about. Monitoring truth is no monitoring device, no matter how accurate insightful data, will improve the outcome unless coupled to a treatment which itself improves the outcome. So the monitoring should lead you to some treatment guidance which will improve the patient's outcome. So what is organ support? The cardiovascular organ support basic is intravenous therapy, vasopressors and inotropes, vasodilators, infusion pumps. Advanced cardiovascular support is intra-aortic balloon pump or extracorporeal mental oxygenation. ECMO is these days one of the very modern technologies, which is not very physiological, but extremely useful in some small subgroup of patients. In our hospital, we have used this for many times. For patient, young patients who are having pneumonia followed by ARDS, no other systems are involved. This trial of ECMO. One or two patients of severe, very high dose of, calcium channel blockers and beta blockers, and they become vasoplegic, non-responsive to any inotropic supports and all that. Those patients we have tried with ECMO and we have got quite a good results with that. Basic respiratory support is oxygen therapy, suction, nebulization, CPAP, intubation, and its facilities are there. You can do mechanical ventilation. Advanced respiratory support includes nitric oxide, high flow oxygen ventilation in case trauma or air restriction. And again, renal support basic means diuretics, peritoneal dialysis. If hemodialysis is there, you can use that. Advanced renal support is the slow low efficiency dialysis, CRRT, extracorporeal blood purification. This we also don't have. Other support basically blood products, microbiology. Advanced support is plasmapheresis, IV, IV. This is useful in certain subgroup of patients like myasthenia gravis and infective polyneuritis or certain poisons. But it is very useful. So let us see what happens with the various monitoring in minimum resource. There is no resource limitation. So you can have whatever is in green is nearly basic, and what is in a red is all advanced monitoring. So cardiovascular support, respiratory support, renal support, you have got everything in that setup, including CRRT, extracorporeal purification, PPV, you have got invasive cardiac output monitoring. So that is a setup where there is no resource limitation. Moderate resource limitations do not have water is there in a way. They may not have bedside so USG, they may not be having IATV, they may not be having Indian nitric oxide, they may not be having CRRT, slate, or extracorporeal. Serious resource limitation, as I showed in earlier slide. Whatever is in red, it may not be available. For renal support, you may have to depend on peritoneal dialysis, and for respiratory therapy, you may not have access to the mechanical ventilation. So that kind of thing. What amount of resource limitation is there is very important, and it varies from the country to country, and poorer the country, more the limitations are. So let us talk about how to manage the patient with limitation, resource limitation, like diagnosis of ARD. You can use extra-chase arterial blood gas, in the ultrasound, you can do targeted pulmonary. You see usually PF ratio and ARDS that will be less than 100, 80, 60, whatever it is that reflects the severity of ARDS. That can be replaced by, instead of PaO2, you take oxygen saturation and FiO2 ratio. So this is one of the articles published in Annals of Intensive Care where they are compared PaO2 PF ratio to the SpO2 and FiO2. That is a very strong and linear relationship, and it can be used in the resource limited sector for the statistics. It has this tool of PF as well. PF ratio is reliable surrogate measure of PF ratio with acute lung injury or ARDS. The paper published in Journal of Cardiovascular Thoracic. So mechanical ventilation and ARDs in the ED, multi-center observation prospective cross-sectional space. So these kind of modes of ventilation also can be used, low tidal volume, use of easier to diagnose under ventilation, higher FIT is accepted. So this Sp.An FIT table is there. How much Sp.An, how much FIT is to be used. You can use this table. Use of invasive ventilation for C and NI for mild cases. FI would to versus the target period of 60 millimeter of mercury and SpO2 of 88 to 95. This is the level of evidence. Low FIT is preferred over high FIT. Deep FIT tables can be used. Recruitment maneuvers in moderate to severe ARDS. Refractory hypoxemia and ARDS diagnosis cannot be made with lack of CSR and ADV in the simplest manner, that is sustained infection. Non-invasive positive pressure ventilation, successful outcome patients with acute lung injury in resource setting. A group of hemodynamic stable patients with severe acute lung injury, non-invasive pulmonary ventilation has a high success rate. So that can also be used. So in conclusion, state of a simple, readily available, affordable recommendation to be there for safe mechanical ventilation, limited resource setting. What is new in ARDS? So these are this table shows you it is a resource setting and resource constraint setting. So what all you can do here? Most of the things can be do. You cannot do feed-based visual patient monitoring. Cloning may be problem. Just how you can do proper low tidal volume ventilation, neuromuscular blockade. Cloning also there is a paper that can be successful of underlying body. How to recognize sepsis? There is a fixed SOFA score which is based on altered mental status, fast respiratory rate, and low blood pressure. The recognition of sepsis is the retrospective analysis of 8 core studies and 1 RCT. And fixed SOFA is as sensitive as a fixed SOFA, and it has been used very successfully in a lot of situations. About hemodynamic assessment and supporting sepsis and septic shock in resource limited setting. The recommendation by 6 clinicians for hemodynamic assessment and support of sepsis and septic shock. Simple bedside tools for assessing tissue perfusion, capillary refill time, skin mottling score, and skin score temperature. So this the capillary refill time is normally seen on the tip of your fingernails. You can be seen in the ear skin also. In small children, you can see some chest. Some patients. So it is normally less than 2 seconds. Such patients within 2 to 4 seconds that perfusion is hampered. And it is compensated shock if it is more than 2. If it is inactive cardiac output, it's more than 5 seconds. So it's very useful. There, this is called as mottling. If you can see, you must have seen in many patients in your ICU that the perfusion is affected because patient is in a job and there is a perfusion affected. And you can see this kind of very severe mottling, whatever we are doing. So they are scoring by Mr. H.I. Ofela, who published it in Intensive Care in recently in 2008. So 0 is no mottling. 1 size is mottling area on the knee. 4 2 is the superior area of the kneecap. 3 mottling up to middle thigh. 4 mottling up to fold of joint like this you are seeing. And severe mottling that extend beyond the ground. This is a French group. And what they are seeing as they have correlated this mottling with survival. And what they found that survival rate is more with score is like 0 to 100%, 2 to 3 survival is 60%, 4 5 survival is 40%. So it correlates well with the survival also, and it is very important feature. Fine. Uh, there is correlation between mottling score and skin perfusion, which has been studied by using a laser, and therefore there is good correlation. So, what is a passive leg raising test? Passive suggests using the passive leg raise test to guide fluid resuscitation in sepsis or septic shock. These are not. So, how do you see fluid responsiveness? You need a weight like this. So, you start in a semi-recumbent position. This down and this up, and you see what are you trying to see? What are you trying to see? You are trying to infuse 300 ml of blood from the lower extremity to the right side of the heart, and you are trying to see whether there is a patient's cardiac output, blood pressure has improved or not. Recommendation that failure guided through resuscitation in sepsis and septic shock to A level. It is recommended. It is not reliable and say in severe malaria and dengue and children less than 5 years. It is advisable to measure rather than just measuring the blood pressure. You, if you have got facility, you measure certain other things like arterial line and with the arterial uniform. And if you have got some mechanism to measure the cardiac output, you can. What which IV fluids resuscitation in sepsis and septic shock in resources. What are it is crystallized ringer lactate and normal tranquilized albumin is the treatment of choice. There have been very large study published in the European journal which talk about not using colloids in a long term because it is associated with the renal injury. When and how much? As soon as possible within 30 minutes. 30 ml per kg in for 3 hours. Fluid responsive by PLR if hypopressure persists. Avoid fluid overload. If it doesn't respond, you can start the vasopressor. Vasopressor start in persistent hypertension, MAP target 65 millimeter of mercury. First line of noradrenaline, dopamine, and target the normalization of plasma lactate levels. If it is not there, this two things will be always there: capillary steam time and reduction in the steam point. These are various modalities of renal support are available. First option is intermittent hemodialysis, PRRT, peritoneal. So if in a resort limited setting, you may not have any access to all of these. So peritoneal dialysis has been observed to be quite useful in such kind of a setup. It is studies published in journals. Peritoneal dialysis as a mode of treatment for acute kidney injury has been observed to be very useful. Peritoneal dialysis is a viable mode. Advantages: minimal trained staff, infrastructure, lesser field streets, less hemodynamic monitoring. PD is observed to be better in acute pancreatitis in certain studies. And guidelines: it is suitable in early care and metabolic acidosis, not suitable for fluid overload and hypercatabolic state. If no satisfactory response is, you have to shift to the conventional. PD has advantage in lower income limited resources and can be the first form of dialysis. Sepsis resuscitation bundle. This is the complete bundle. It says resource limited setting, you may have to omit something like you may not be able to measure serum lactate. Blood pressures can be obtained in the event of hypotension. Deliver an initial 20 ml per kg of slab can be given. You can apply vasopressor. Okay. So these other rest of the things can be managed in the bundle except few things. One modality to suggest which can help immensely limited income setting is ultrasound guidance. What is the use of ultrasound guidance? Is that it is non-invasive, reusable. You can treat the patient, you can identify the disease, treat the patient, and see the response. And it is very non-invasive, it is portable. And ultrasound skills have become mandatory for anesthetists nowadays, either for regional block on critical care. It is such an important tool. It can help you in many tricky situations. Echocardiography can tell you left ventricular ejection fraction, STS, ventricular collapsibility, fluid resuscitation is adequate or not, left ventricular hypoparameter. So, a variety of things you can come to know from echocardiography. Ultrasound has got main role in diagnosis pneumothorax, may be helpful in pulmonary embolism, fluid overload. And day by day, its utility is increasing, and it is mandatory to have some kind of a training in managing the patient, doing ultrasound and certain diagnoses. So now last year we come to our ICU. We have got a level 3 ICU done by Department of Anesthesiologi and critical care. We have got 1:1 nurses ratio. We are round the clock residents and consultants are posted. Mainly our turnover is around more than monthly, around 612 patients, 50% are medical. Haemodynamic monitoring, we use non-invasive clinical analysis transduction. We have got video, we have got a cardiac output monitoring device. One of the very well equipped. And renal, we have got IIMS late. CRRT, we have to take a help of. Small lab which does point of care, PCP, BNP, probing, PK, John Rule also, there are various ventilators, modern gadgets there. We do very commonly one of the centers to do the cloning patient for ARDS, and it is observed to be very useful. This is the team led by the consultant anesthetists. We have got trainees, we have got trainees doing MD anesthesia, trainees doing critical care. What you say? Thank you very much. What is it? Thank you. Thank you. I'm sorry, this presentation would have been much better, but the slides are not functioning in the proper mode. So there are a lot of slides which need to be deleted, but if you are having that option, it automatically, omits them. So that's why.
Yes.
Okay.
Yes. It's okay, Prof. Thank you very much, Professor, for your presentation. It's okay. We now continue to discussion session, Professor. And currently, we already have one question from Dr. Printa, a fellow intensive care. May I read the question for you, Professor?
Yeah, what is it?
Yes, Professor.
Yeah.
There is a.
What is the question?
The question is, in one of your slides, you said volume control ventilation is more preferred rather than pressure control ventilation. Can you explain about this? Why you prefer using the volume control ventilation, Professor, rather than pressure.
I must state in some different perspective. There is nothing like this. That volume control is preferable or pressure control ventilation. Both are got different indications. We in our hospital mainly use pressure control, and certain situations we use volume control ventilation. Nothing like that. Right?
Oh. Okay, Professor, thank you. Okay, Dr. Primta, are you have anything more to ask to Prof. Dilip? Okay, if there is none, for the other participant, if you have anything to ask or anything to discuss with Prof. Dilip, you can write the question at the question and answer chat box, and Prof. Dilip will give you the answer of your question. And before that, yes, Professor.
Or they can email me questions. I will answer to them.
Yes, Professor.
If they want. Right.
Okay, Professor. Okay, Professor. Can I ask some question, Professor? Perhaps. Yes. In the yeah, thank you, Professor. In a resource limiting setting, if there is we have a sepsis or septic shock condition in a patient, what choice of fluid that we can choose, Professor? We can choose crystalloid only, or we have to choose colloids in septic.
Like the patient in the sepsis, septic shock, resuscitation of a patient.
Yeah, with resource limitation.
So if it is a resource limitation, if it is to that extent that you don't have crystallized, then you can hardly do anything. Isn't it? So the crystallized is a fluid of a choice for resuscitation of patient, and ringer lactate is a fluid of choice. And it is given within the first 3 hours, and you monitor the lactate of a patient, and according to lactate. Albumin is given for the resuscitation only when the patient is having a low blood pressure and patient is requiring inotrope, and at that point of time you can use colloids. Other colloids like ACE heterostat, gelofusine, these colloids have lost their popularity over a period of time because of a lot of studies have come up which demonstrate that use of these colloids during the resuscitation is associated with some renal issues. I have worked in UK, and many ORs of the United Kingdom, they are removed colloids from there, that so people should not use it at all. It is better to use the inotrope rather than using too much chloride or crystallite at one point of time.
Okay, thank you, Professor, for your answer. All right. If there's any question, is there any question from the other audience? Okay. Okay, if there is nothing more, or if there's nothing more question from the audience, we can finish this session, perhaps, or we wait for another question, Prof. Oh, okay. All right, Professor. I think we can wrap it up. Thank you, Professor, for your presentation. All right, Professor. Finally, we reached the end of this lecture. Yes, Professor.
Thank you, Andriamuri. Thank you for inviting me. Thank you, everybody. Namaskar.
Yes, Professor. I would like again thanks to Professor Dilip for your excellent presentation, and all dear audience, the conclusion of presentation today is there's been a lot of mortality due to resource limitation in low-income countries. The physicians need to utilize all the resource they have to make a better assessment and diagnostic. But a good diagnostic alone is not enough to properly treat the patient, because a good diagnostic will be useless without a proper treatment. And now, thank you, Professor, for sparing your time with us. Hopefully, this lecture will give benefit for us all. And also, I hope we see again real soon at the next event that we will do next year, Professor. Thank you, Professor. Thank you so much for your time. Yes, Professor.
My pleasure.
Okay.
Thank you very much.
Thank you, Prof. Dilip, for your kindly.
Thank you so much.
Huh?
Thank you. Sorry about that, sir, but I think there was problem both ways. It was slides were not moving.
It's okay, Professor. It's been going well. Okay, Professor. Okay, from now on, I'll give it back to the Master of Ceremony, Dr. Rico Gandhi. Dr. Gandhi, please, it's your time.
Okay, I will leave the meeting. Thank you so much.
Sorry,
right.
I'm sorry, Dr. Professor. Can you wait just a little bit more? We would like to take a picture with all the attendees and the panelists. Can you give us 5 minutes?
Sure. Why not?
Okay. Okay, thank you for Professor Dr. Dilip Shende for the sharing of knowledge. I hope everyone can take home some knowledge from the presentation of Professor Dr. Dilip Shende. Now, before we close this session, we would like to documentation of some of this event. We would like to, I hope all the panelists and the attendees to open the cameras, and I would give the clue of 1, 2, 3, and we can take the picture. Okay, from the first slide of the panelists and the next slide, participants. Next slide. Okay. The next slide. The next slide. The next slide. Okay, 1, 2, 3. The next slide. Okay. Now for the closing ceremony, I would like to thank you for Professor Dr. Dilip Shende for your time. Thank you very much, Professor. I hope we can meet in person soon enough.
Yeah. Whenever you have got a conference, then you call me. I will definitely come and meet you.
Okay, thank you very much, Professor, and thank you for our head of Studi Program of Anesthesiologi and Intensive Care, Dr. Andriamuri Prima Putra Lubis.
Thank you, Prof. Dilip.
Oh, thank you so much. Andriamuri. Thank you so much.
Thank you for all the attendees that have shared their time with us today and attend this meeting. And for today's agenda, I will close the international guest lecture. Thank you very much. See you again in the next international lecture. Thank you.
Thank you.
Okay, Professor. Thank you, Professor. Thank you, Professor.
Thank you, Professor.